over to you, Dr. Mahesh. He's consultant glaucoma services at Ahalya Foundation, Palakkad. He was my junior in JIPMER, both MBBS and in PG. And he was in LB Prasad. He has done a lot of innovations and worked abroad as well. Over to you, Dr. Mahesh.
Thank you, Dr. John. At the outset, I would like to thank KSOS for the opportunity. And after this elaborate talk on intraoperative gonioscopy, KDB, some intro into eye stent, microhook, the sad part about talking about MIGS being the third speaker is that we have a lot of overlap between this microscope adjustment, patient adjustment, the indications for the surgeries. So I will be talking about what, why, and how of the GATT. In this, I will take you through the introduction to the world of MIGS, introduction to GATT, the intraoperative gonioscopy, the surgical technique, intraoperative complications, post-op management, and also the advantages of the procedure. So as Dr. John has already spoke about MIGS, it was described in 2012 as an ab interno approach. It's minimally traumatic to the target tissue, faster operating time, modest efficacy, high safety profile, and a rapid recovery with minimal detrimental impact on the quality of life. With the so many surgical options available for a glaucoma surgeon, whether it is the traditional glaucoma filtration surgeries or the MIGS now, I will be mainly talking about excessive excising or the cleavaging the trabecular meshwork, the GATT procedure. It was developed by Dr. Davinder Grover et al. At the Glaucoma Associates of Texas. It's a non-bleb forming MIGS procedure where the Schlemm's canal is de-roofed. It's a conjunctiva sparing, ab interno, and most importantly 360-degree trabeculotomy. It was initially started as a illuminated catheter-based procedure and now extensively used with the 5-0 proline for developing countries or where socioeconomic considerations are considered. This is the same what I told, the overlap, the microscope rotation. What Dr. Neetu told about the apps that are available in iOS Apple form, you have this measure app where you can keep it at the podium of the microscope and you can measure the angle 30-degree or 45-degree and then mark it. Just a few tips to identify the trab meshwork by the pigmentation of the trabecular meshwork, if it is a PDS case or a PXF glaucoma or post-traumatic. Then you can do actually a provocative gonioscopy by inducing hypotony and causing reflux of blood into the Schlemm's canal and see where the trabecular meshwork is. And also by staining the trabecular meshwork with trypan blue, you can actually identify the trab meshwork in less pigmented trabecular meshworks. The when, how, and why of GATT. Patient selection, most important, should be a cooperative patient. And then there are few contraindications or relative contraindications like cervical spine problems where the patient head cannot be tilted to the required degree to have a good view of the angle. And then bleeding diathesis is when to start with, better to avoid such cases. Or if patient is on antiplatelets, you can ask the patient to stop antiplatelets for 5 days prior to the procedure. Primarily the indications to start with were primary and secondary open angle glaucoma, and it was done as a standalone procedure or along with cataract extraction. If you want to start any MIGS procedure, better to start on patients whose intraocular pressure is well controlled on more than 2 medications, so that your aim is just to decrease the need for medication and not achieve a better intraocular pressure control. Mild to moderate cases better to start with, but nowadays with increased experience, people even do with severe diseases. Pre-operative gonioscopy, that means office gonioscopy, is an absolute must to rule out any kind of angle closure or any kind of PAS or any kind of neovascularization. These all should be ruled out. And practice few sessions of intraop gonioscopy in a routine cataract case and try to touch the angle with the Sinskey hook as Dr. John mentioned. Preoperatively, in combination with cataract extraction, a detailed consent has to be taken. Discuss the recovery delay. Patient should not have a high expectations like our usual cataract surgery. Post-op day one I should see 6/6, because as Dr. Neetu said, there can be hyphema and there can be a delayed visual recovery. Discuss the head positioning as against eye stent or a KDB where you see minimal hyphema. Since you are dealing with 360-degree deroofing of Schlemm's canal, you are expected to have a little bit more amount of hyphema in a GATT procedure. So post-operative head positioning with a head end tilted should be discussed with the patient pre-op itself. Now, which to be done first, either cataract surgery or MIGS procedure? There is a well-established scientific basis to tell that it is only the surgeon's choice. There appears to be no significant angle visualization difference whether the surgeon chooses to complete the angle surgery before or after phacoemulsification, and it should rely only on the surgeon preference. When I prefer to do it after the cataract surgery if the cataract is soft. If the cataract is NS3 or 4, I would like to do it before so that my phaco energy doesn't cause corneal edema and impair the angle visualization if I want to do the MIGS procedure later. Intraop positioning as against phaco where your elbows are maintained at the sides and you have a coaxial lighting. Here you have to actually stretch with your, if you are a right-handed surgeon, your left hand should be holding the gonial lens and it will be outstretched, and there will be increased distance between your corneal incision and the angle that you are going to approach. These are the traditional instruments that were needed for a trabeculectomy, and when you compare these instruments with the amount of instruments that are needed for GATT procedures, see the decrease in the amount of clutter. About intraoperative gonioscopy, visco, I prefer to put the visco on the lens so that you have as minimal visco and it doesn't keep spreading over the cornea, and you rest your head either on the forehead when you are doing the right eye when you are a right-handed surgeon, or on the zygoma for the left eye. Don't use the lens to guide the eye. That means don't use the lens sitting on the cornea to force the eye to guide it to the angle that you want, because that will cause folds on the cornea and will impair your visualization. And as Dr. Neetu said, zoom in, zoom out to the desired area. And this is one good intraop visualization of the angle that you will get if things go fine. Just take into this text now, and when I discuss about the video, I will discuss what I actually mean by these. Avoid limbal vasculature. We don't want blood mixing with our visco and impairing the field of visualization. Usually a 2.2 millimeter incision is sufficient to do a standalone procedure, and if you are opting for a 2.8 or 3.2 millimeter cataract surgery, that also is good enough. A temporal incision is made for the entry of your hook to hold the suture, and this is what tangential incision for the suture entry. Intracameral pilocarpine is used if you are doing a standalone procedure that will make the angle open and also will protect your anterior lens capsule from any kind of injury. Then if you see reflex heme, fill the anterior chamber and keep it firm. And at the end of the surgery, half fill the anterior chamber with visco or air tamponade to decrease any amount of hyphema. So this is the surgery which was done when I was at LVPI, and after getting the visualization, so if you are starting to do cases, better to do your visualization first before starting the surgery at all, just to confirm that what angle you could visualize in the clinic, you are able to visualize the same at the OT table also. You should not make all the incisions, you have entered everything, you have opened up your gonio lens, you have opened up your suture, everything, and then you are placing and checking the angle and you are not able to visualize the angle, then all the consumables that you have used are gone waste. So get a view and then, so see the orientation of the incision that is made. This is tangential view, tangential incision for introducing the suture. If you make a usual horizontal incision for introducing your proline suture, your suture will lie in the center of the pupil. And taking this suture to your nasal angle and passing it through the deroofed Schlem's canal will cause kinking of your suture, and it will not pass smoothly through the trabecular meshwork. So here we have to have a tangential incision so that the suture will go tangentially like this and approach your nasal angle. So here I have tried to avoid as much as possible limbal vasculature and made it a little anterior corneal incision so that I don't encounter any amount of blood with my visco, which will impair my visualization of the intraoperative angle. This is one thing which we have to keep in mind. Once we place the gonial lens, because of total internal reflection, you see the suture is actually passing from here, but inside the eye the suture is here. You will feel that refraction because of refraction at different levels. You have to get used to it. Otherwise you will go on hitting the cornea and you will cause micro DM detachments. And then have a good incisional goniotomy. I'll just show that once again using an MVR blade. You approach the nasal angle and have a good incisional goniotomy. You see that when I dip it, you can see the deroofed Schlem's canal. Behind that is the Schlem's canal. And now with the use of forceps, this is a ERM peeling forceps or Grieshaber forceps. We hold the suture, which is made bulbous with the help of heat cautery so that it's atraumatic, and then keep passing it along the deroofed Schlem's canal. After almost around 20 to 25 or almost 30 strokes, it passes 360 degree and you can see the bulbous tip of the 50 proline suture which has traversed all 360 degree and has come here. And the first time that you will see that, it will be a wow moment. You wouldn't be expecting it. You keep on pushing it, and the moment you see it, it will be something you will remember it forever. And once you have seen that, you have to pull it anteriorly and holding the trailing 50 proline with the McPherson forceps, you give traction and see the suture that is moving complete 360 degree. You see the movement of this, that is ripping apart the 360 degree trabecular meshwork, and it has come out. This is another case which we did the surgery for a silicone oil filled post VR surgery glaucoma, and you can see this. Actually, I took the patient for TRAB, and then intraoperatively I tried a gonioscopy and could see the angle very clearly. You can see the oil bubble subconjunctival space, which is actually a risk factor for bleb failure. And then I did a 360 degree goniotomy. At 2 weeks, you can see that nicely ripped apart trabecular meshwork, completely open trab meshwork. This is called the cleft that we get after the GATT procedure. Post-op follow-up, hyphema is expected, so we advised head and elevation. Initial post-op day IOP may be high because of hyphema, the retained viscoelastic that we have put to decrease the hyphema. And depending on the severity of the glaucoma, we usually don't stop all the anti-glaucoma medications on the post-op day 1 itself. And to decrease the initial hyphema and the inflammation, we start the patient on Predfort, and at 1 week post-op, we have shifted over to either low-potent topical steroids or even NSAIDs. There was a good discussion sometime back about role of pilocarpine in post-MIGS cases to prevent PAS formation, because we are creating raw surface and the iris that is at the periphery going to the raw surface can cause PAS. And it was advised to start pilocarpine at least for 1 month or 2 month post-op to decrease this. But we could see a silver lining during the dark times of COVID when pilocarpine was not available, and we were doing these cases and we could see that actually nothing of that sort was happening. So we slowly withdrew pilocarpine from the post-op regime. As of advantages of all the MIGS, it achieves 360-degree trabeculotomy. It's a conjunctiva sparing procedure. It's a cost effective as against KDB or eye-track catheter. Learning curve is a little steep, but it is short. These were the few questions that we had to answer when MIGS was introduced. How much IOP decrease, how long, what's the cost, is it available to us, is it easy to learn? I think over the years we have done well, and it will test the stand of time. And my take clinic message would be gonioscopy plays a very important role in perioperative preparation of MIGS, and practice makes a man perfect. GATT is safe, effective and cost effective MIGS available for Indian scenario. Thank you.
Thank you so much, Dr. Mahesh, on that extensive information about suture GATT. Next is actually Dr. Prasanna Venkatesh Ramesh talk, but since he is not there, I'll be presenting for him. The talk is on iStent, iStent Inject, and the Metaverse Mix MedLab. So don't go away after the talk, because you will be introduced to the Metaverse with virtual reality, augmented reality headset and all that. The Metaverse person is there sitting at the back. Raise your hand. Yeah, you can experience a Metaverse before you go, okay?